Hi everybody, thank you so much for coming to our surgery-themed GASOC Journal Club today. I'm Alice, I'm one of the surgical reps for GASOC, and I'm also on the World Orthopaedic Concern Trainees Committee. We do these journal clubs every other month, and we rotate between surgery, obs and gynae, and anaesthetics as part of GASOC. And it's a real pleasure to introduce Zahra Jaffry today, who is also part of the WOC collaboration, and she is an ST4 trauma and orthopaedic registrar in the UK, based in London. She has experience working in Malawi as part of her medical elective, and she also has experience working with the World Health Organization as an intern. And I'm very excited to hear her presentation today on this paper, which you should all be able to see on your screens at the moment. So childhood musculoskeletal impairment in Malawi from traumatic and non-traumatic causes, population-based assessment using the key informant method. We'll spend some time going through the paper, and if anybody has any comments or questions or would like to share anything, then please feel free to either put it in the chat or just raise your hand in this meeting, and we can talk about everything. Yeah, I'll hand over to Zahra to hear about this paper. Thank you.
Okay, great. Thank you, Alice. So I can't actually see the chat function because I'm sharing my screen. So if, Alice, you see anyone who wants to ask a question, please feel free to interrupt me. That's absolutely fine. So Alice has told you the title of the paper. It's a bit of a mouthful, so I won't say it again, but I'd start with some background. It's published in the BMC Musculoskeletal Disorders Journal, and that has an impact factor of 0.8. It's a fairly recent paper. It's published in 2021, so last year, and you can see from here that we have quite a few familiar names in the world of global surgery, and so you can see from the affiliations that they are a mix of people who are based in Malawi as well as the UK. So let's see if I can go to the next slide. Not working. There we go. So I have put up these papers just to give you an idea of other work that these authors have done. And so as you can see, they've done lots of other population-based survey-based work. So the one I wanted to draw your attention to was the one at the top, Childhood Disability in Malawi, a population-based assessment using the key informant method. A lot of the authors are the same, and that's actually because this paper, which is based on data from 2013, is also the basis for the paper we're talking about currently. So they're using the same set of data. This is basically a sub-analysis of the data they got back then. Now you'll see under that first title, correction 2, and I just wanted to make you aware that the correction is actually just about a missed acknowledgement in funding and nothing too disastrous. Again, more of the background. The reason why they did this paper is that surveillance is very important. It allows you to monitor child disability in different countries and then talk about improvements in health services and appropriate care. Past studies have used different tools and different methodology, and that makes it difficult to compare across countries. The 2008 National Census in Malawi estimated a 2.4% prevalence of disabilities in children. But child-specific methodology wasn't used, and they think that this figure is likely an underestimate. And so they wanted to use another method, the key informant method, which lots of other papers have used, and I'll talk about those later. And that would give a better prevalence, or a better estimate of the prevalence and the causes of childhood impairments in low and middle income countries. So a lot of people present summaries as PICO, but because this was an observational descriptive study, I think SPIDER is a more appropriate acronym to use here. So we've got a sample, phenomenon of interest, design, evaluation, and research type. So they looked at children under 18 from 2 districts in Malawi, Fiolo and Nitu, and they were looking at musculoskeletal impairment from traumatic and non-traumatic causes. As I said earlier, the design method involved a key informant method, population-based assessment, which I will tell you what that is exactly in a bit. And it was an observational cross-sectional study. So the things that they were looking into were prevalence, demographics, the impact on schooling, etiology, and treatment of these conditions. And the research type was quantitative. So what is KIM, or key informant method? So they essentially found 250 volunteers from each district, 500 in total, trained them for a day, and then sent them back into their communities to identify people with disabilities over 6 weeks. And this is all disabilities because of that first paper I talked about. And then they've done that subgroup analysis, which is the MSIs. The children were sent to screening camps after being identified by the key informants, and they were then screened by experts, and that's orthopedic clinical officers, which is what OCO stands for. And then they would ask them history questions such as these that you can see here, the 7, which includes is any part of your body missing or mishappened? Do you have any difficulty using your arms or legs or any other part of your body? Do you need a mobility aid or prosthesis? Do you have convulsions, involuntary movement, rigidity, loss of consciousness? And included are seizures associated with other MSI such as cerebral palsy. And then if the answers to any of those are yes, then has it been more than 1 month or is it permanent? Because they're looking for chronic conditions here. And just a side note, these experts also had a day of training before they were enlisted to be part of this study. So the results, you have 15,000 children that were referred by key informants to the screening camps. However, 7,220 were actually seen here. 1,094 had musculoskeletal injuries, impairments, and I put the S in brackets because 24 of those children had multiple etiologies. 145 of them were traumatic MSIs. So there was some missing data. They didn't have gender for 252 of the children that arrived at the screening camps, and 132 had missing etiology, and any other missing data was included in other categories in the data that was presented. So they reached the conclusion that the final prevalence was 6.6 per 1,000 of MSIs, and they had a number of non-attendees, and that was 52%, as you can see from the numbers above. And they assumed that the prevalence was actually the same in the ones that attended versus the ones that didn't attend, and they combined the result and then used that to extrapolate and use the total number of children in the villages. There, 338,235, also as a basis for the extrapolation. So demographics, you can see there's a almost 50-50 split in that you had just over half, 51.5% from the Thiola district, and that means the remaining were from the Netu district, and 49% were female. So you can see from figure 1, this is the age distribution of children with MSI. You can see that a lot of it is distributed towards the younger age group, whereas if you look at figure 3, the number of children with just traumatic MSIs, you can start to see that average, it starts coming at a later age. So it's about 4, 5, 6, and then age 9 as well. Then they also went into more of the socioeconomic background of the children that were presenting. 35% of parents were illiterate, 88.8%, which is a great majority, had a household income of less than 12,000 Malawian kwacha, which equates to about $28 per month. And this figure is from around 2013. So now we're going to just talk a little bit about the schooling and how that was impacted by MSIs. So they were able to subclassify all of the MSIs into neurological, congenital, trauma, acquired, non-traumatic, and you can see the numbers here that they've assessed, but I just want to draw your attention to where the red box is. That's the number of children that attended schools. So you can see that quite a low proportion of the ones that had neurological MSIs actually went to school. That's 28.8, and they do bring that up in the discussion, and they said that not no children attended schools with resources for disability, so it would have made it harder for them to go to school without the sport being there. So if you look at the figure below, they've also shown how what the distribution of the anatomical location is for these children. So you can see here that for all MSIs, quite a lot of them affect the whole leg, the whole arm, or the whole body. Now, if you just look at the results from trauma, this is figure 4, the graph at the bottom, you can see that actually the majority of them fall to the elbow. The elbow is the most commonly affected part of the body. Here we see that RTAs cause 4% of the MSIs, domestic violence 2%, and other incidental accidents 47%. So if you have a bit of background to do with trauma, you'd realize that these numbers are a lot lower than what you'd see for adults in Malawi. And again, this is something they discussed, and they found that actually a lot of this may be due to underreporting in the case of domestic violence and with road traffic accidents, because obviously at that age you have fewer drivers. That's probably a reason for the lower numbers in RTAs we're seeing there. And then they also had a look at traumatic MSI diagnoses, and the vast majority of them were because of burn contractures. So what were the treatments that they found they needed? A lot of them didn't need any treatment, but the top 3 treatments that were required were physical therapy, occupational therapy, and surgery. And so this has highlighted a need within the communities, within Malawi, of treatment bases. And that's essentially why they have done this study. It's to highlight this need. So I want to talk to you a little bit about the limitations, mainly coming down to the method. Does the key informant method really, as the authors had claimed, give a better estimate of overall prevalence over other methods, allow better comparison across countries? And then, are the 2 districts representative of Malawi? The paper justifies the use of only 2 districts because of the availability and the proximity to healthcare services, and these districts approximate the socioeconomic average of the rural district in their region. So the last point I wanted to make about limitations is a 52% non-attendance rate acceptable, and is it safe to assume the same prevalence in non-attendees as attendees? In my opinion, it's likely to lead to an underestimate, as MSIs make it harder for people to travel. So I want you to think about all of these questions when it comes to our discussion, but I do want to give you a little bit more of a background so that you can make informed discussions. And that's by looking at a few other studies. I won't go into too much detail here, but I do just want to highlight a few things. And that is the 3 studies here on the left. So the prevalence in this study was 6.6 out of 1,000. The census in Malawi showed that children, the prevalence of walking disability in children was 0.4 out of 1,000. And in another paper that was published more recently in 2022 by another group, found that the prevalence was actually closer to 65 out of 1,000. And so I just want to draw your attention to could a reason for this vast difference in numbers be the methodology? So you can see here, especially between this one and the more recent Malawi one, there is a big difference in the methodology. So this one uses KIM or key informant method, and the other one uses a random cluster survey. So just to explain what that is, what this group did is that they looked at the census and thought, okay, let's try and get a more accurate estimate of what the prevalence is. They also did reference this current paper and decided they wanted to do something that might be a little bit more accurate. And so what they did is they had a map of Malawi, they split it into all of its districts and then what they call clusters, and then chose the clusters at random and that covered all of Malawi. And so they had 27 clusters covering the entire country, went out there and collected data from them about musculoskeletal injuries in children. And so I'll leave it to you to decide whether or not that's a better method, but I do want you to have a look at the prevalence underneath. If you look at other studies that use the same method, Rwanda, Cameroon in India, Cameroon in another study, that you can see that, again, the prevalence rates that they found were slightly higher. And then there is one study, the Bangladesh one, which used both. And actually, you can see that the prevalence rate at the bottom row there with the key informant method was 6.2 out of 1,000 versus 8 out of 1,000 using the random cluster survey method. So actually, that throws a spanner in the works, because is there really much of a difference between the two methodologies? Another thing I want to draw your attention to is the consensus in Malawi used walking impairment as its classification for MSIs. It didn't say MSI specifically, it simply asked, do you have trouble walking? And that may be why their prevalence is a lot lower than the other studies. And if you look at the other studies that used MSI as a classification, you'll see that the prevalence rates are higher than simply using walking impairment or physical impairment. Then the other thing I want you to talk about are the actual questions. So again, the consensus simply asked, do you have any problems walking? But there were 2 different sets of questions that were used in other studies. So our one used a rapid assessment method, and so did the more recent Malawi paper. But there were other groups that use the Washington group of questions, and I'll show you what the difference is. This is the rapid assessment of a musculoskeletal impairment one that I mentioned earlier. So this is the one that was in the paper that I talked to you about in the methods, and then this was the Washington group questionnaire. And it's actually a lot more focused on functionality. Have you got difficulty walking? Do you need any assistance? How far can you walk? Essentially is what they're trying to determine. So I'll bring up this table again at the end just to aid your discussions if you would like it. But I do want to end on a high note and talk to you a little bit about the strengths. The key informant method overall is more reliable than self-reporting. The large numbers that they've used here, and I'll take you back, and actually they are quite large numbers. If you look at the number row in this table, our one shows that they actually got data from 1,094 people. It's not as much as the census, but it is still more than the more recent Malawi paper. And that does contribute to some epidemiological data overall. And their prevalence is actually comparable to LMIC's. So if you look at our one again, and then compare the prevalence rate to the study from Bangladesh and the study from Cameroon and India, actually it's not so different. And it has highlighted an unmet need for children with disabilities in Malawi, including access to pre-hospital care. Essentially, their conclusions say that preventing or reducing disability is a result of reducing delays to presentation. And then schools with specific resources for disabilities, physical and occupational therapy, and surgery. So overall, this has been a very useful paper, and I hope it generates a lot of discussion. If you have any questions, please feel free to ask me now.
Zahra, thank you so much for that. That was really comprehensive, really well thought out, and really interesting.
No problem.
The first question that we have in the chat is from Edward Jenner. Hi, Ed. Saying, was there any financial support for children to attend, i.e. travel subsidies, etc.?
So they didn't actually mention that in the study. I didn't see that in the discussion either. So actually that might be one of the reasons why so many people didn't attend. So I actually put it down to travel, but actually that's a very interesting point. It might be some financial barriers to getting to where the camps were based. One thing they said is that because they did have multiple camps, maybe they weren't too far from the districts that they'd be based in, but it's difficult to say without much detail.
Yeah, Lambert, I can see your hand is up. I'll get to you in a second. It says he's sorry he doesn't have a mic. His selection bias and his experience of working in similar populations in Western Zambia, is not being able to afford to actually attend the part of the process of your method where you're counting. So, and I've had similar experiences talking the people that we were of whom features we were measuring in Ethiopia, the biggest barrier to accessing care and you know, as highlighted by the 3 delays model, is distance and time and the financial money of actually getting something. Yeah. Lambert, did you want to use your microphone or type in the chat box?
Okay, thank you very much, Alice. Thank you, Zahra. I really enjoyed that. This is my first time on the Journal Club, so I just want to make some contributions and observations from the way from what I've seen so far. I appreciate the limitations of the study because 52% of those children who were not captured is quite significant. So one would want to really, like you pointed out, question whether you can really bank on the outcome of this study. Secondly, also the fact that they focused more on lower limb impairments, because the question was whether the kids have any working impairments. And we all know that the musculoskeletal system encompasses way more than just lower limbs. The upper limbs, the spine, and the rest of it. Or when one is talking about just working impairments alone, we want to really capture the whole gamut of what musculoskeletal impairments entail. Then also, one of the things one would have loved for them to factor into the study is the community, the type of community, whether it's a rural community or an urban community. How developed is that community? Because definitely for a more developed community, you're going to have more traumatic MSIs, especially from road traffic accidents. For example, where I practice, even though the community is not developed, but we have a lot of road traffic accidents contributing to MSIs in children, because we have kids running along the road, running along the street, going to schools and getting knocked down by vehicles and all that. So we see a lot of them, more from road traffic accidents than non-traumatic causes. So it would have also been good to state that fact about the community where this study was carried out. Then I also appreciate the fact that they were able to factor in neurological causes of MSIs, because it will take a whole lot. It's easier to diagnose traumatic MSIs than neurological causes, because you need a lot of history, examination, if possible, some investigations to go along with it. And all in 6 weeks of this research, I think is quite commendable. Thank you very much. That's just what I wanted to say. Thank you so much.
Thank you so much, Lambert. You made some really interesting points. Can you just, I know where you work, but can you just tell everyone else who's on the call and who might be watching this back on YouTube where you're based and what your services are like?
Okay, thank you so much. Like you know, my name is Lambert. I'm a resident doctor. I'm a trainee surgeon at a hospital somewhere in Kaduna State in Nigeria, a teaching hospital. We are located more or less in a semi-rural area, because over the last 5-10 years, development has been encroaching into these parts. So it's not as bad as it used to be previously. About 10 years ago, the health-seeking behavior around these parts was not too good. So we have challenges getting people to accept orthodox treatments. For example, like what we're talking about now, MSIs in children. We've had this long drawn battle with traditional bone setters. So whenever we have children that are involved in trauma, accidents, burns, we have them being taken to traditional bone healers who end up making matters worse, so these children present with gangrene, mangled limb, mangled extremities, and very difficult cases to manage, and a lot of them will eventually need amputations. But in recent times, we've been able to push across from public awareness and education. Of course, it's not going to be done in a day, but then they are really beginning to accept the fact that we have good outcomes managing some of these trauma cases. I've done some rotation in orthopedics, at least 6 months rotation. That's part of our core surgery training before we can qualify for our exam. So we'll be able to see some of these things. So that's just a summary of what's going on here. Thank you.
Thank you so much for sharing all of that with us. That's really, really interesting. I think talking about health-seeking behaviour and having that dichotomy of two types of health systems, sort of traditional health and then the biomedical health systems that we think is our version of traditional health. I wonder if we go back to the point that Ed made about not having remuneration or money for traveling to attend these clinics. And I think that then highlights a bit of a difference between these cluster randomized surveys and this key informant method. Am I right, Zahra, in thinking that one of the things that this project did was then refer children appropriately to services rather than just counting? I think sometimes what's difficult for participants in these studies is that often they have people turning up with clipboards and counting them and giving this kind of promise and hope for something to actually be done about their disabilities or their kids with disabilities, but then never hearing or seeing any health professional again in that child's life. I think something about having this key informant method gives it a bit, like it says in the paper, a bit of a kind of community vibe, a bit more action as opposed to just kind of counting for service provision. I don't know what you think about that. If anyone else has some thoughts.
Yeah, so I'll actually just take you back to the slide here. Not implementations, the results here. I'm just going to move this slightly so I can see it too. So you're right. I think that is the problem with a lot of studies, is that people go there with clipboards, count, and then sort of leave the problems as they are, which shouldn't be the case. In my opinion, it doesn't seem very ethical either. Here you can see that they've looked at people who have already received treatment, but then also treatment that needs to happen. And actually all of these people that did need surgery, did need occupational and physical therapy, they did make those appropriate referrals. It's just that they've also just highlighted it in the paper so that they know where resources need to be allocated and how. So I think that was a nice point about the paper, but I do just want to highlight, because I just had a read of Ed's comment there as well, is they did also actually do that in the more recent Malawi paper, which looked at the random cluster survey. So they had the ones who were collecting information, it was medical students as well as orthopedic surgeons who went out in these groups into those communities to collect the data, but then they'd also be able to make referrals or do some of the treatment there because the orthopedic surgeons were there, and that could be plastering if that's what was required. So I think it is something that we're seeing more recently in some of the papers that I've noticed, certainly, is that they are, I don't know whether or not they did it because they wouldn't comment on whether they did actually treat the injuries they were seeing, but now we are actually seeing it in the papers. They've written it, these people were referred, this is how many were referred, these were the people that were treated and how many were treated.
Might give Ed a bit of time to type if he has any comments to that, because his microphone's he doesn't have a microphone. I think that's really promising, isn't it? That's a bit more optimistic. I think it's definitely a strength of papers that are coming up. It does seem interesting that doing this work are orthopedic surgeons, because I mean, if you wanted to optimize productivity, there's probably a lot of people who'd be able to fill in that role of kind of counting. But I suppose actually it is a skill of deciding what people's kind of musculoskeletal impairment is, and actually if they are then referring them on, then that is something that you need to be quite skilled in doing.
Yeah, and actually I think they found that if there were orthopedic surgeons going on, they actually had lower numbers of referrals, because they'd realised people who weren't surgeons thought a lot more conditions needed surgery than actually was the case. So
yeah.
I think,
I suppose they would be referred to the orthopedic surgeons, and then the surgeons.
which then they, exactly. So sorry, I just saw Ed's other the comment that I wanted to actually answer was, I might have missed this, but was there any discussion of the reasons why random cluster sampling probably gives a higher prevalence than key informant? So my take on this is that because random cluster sampling covers essentially the entire country, or a much wider area than just 2 districts, which is what our paper was doing, I think, and they actually go into those communities and do the surveys there rather than telling them all to come to a specific screening camp. I think that's probably why you're picking up on, they had a 96% response rate, whereas we only had a 48% response rate in our paper. And so that's why I think, you know, a lot of the non-attendees in our paper probably did have higher proportions of MSIs, and that's because of what I highlighted earlier about not being able to travel, but also, you know, what many of you said is that, you know, the financial barriers to that, which were almost eliminated because of the random cluster method. So I think that's why the prevalence is probably higher. And, you know, I mean, arguably it was maybe a little bit more accurate as well.
Yeah, absolutely. What do I wonder about bringing the discussion a little bit to another comment. Oh, hang on, I'll read Ed's comment first. Thanks, Zahra, to good points. Agree, probably eliminates selection bias. Another extension to these types of studies is qualitative analysis, exploring health-seeking behaviour and the barriers. Yeah, absolutely. Another good comment from Ed there. That would be an interesting study. And I think if anyone is listening to this journal club, or even present at the moment, who is in a place where these studies have been done, then it's a real opportunity to conduct research into this, because it would be really valuable. And also, I think even just the point you said at the start, Zahra, that this study was published in 2021, but the data is from 2013. So it might be, you know, this is really common across the board, that people have these projects where they collect a lot of data, but then are limited by what they can write in a 3,000 word publication, and so have a lot of data held back that still needs kind of analysing and publicising. So again, if people are interested, I think it is worth it. A bit of a long shot potentially, but getting in touch with authors of some of the papers saying, hey, would you need help reanalyzing this data? I'd really like to get involved. I think it's quite a nice opportunity for people to do that. Oh yeah, and then Ed has said, talk to Kieran Agarwal Harding about qualitative exploration of MSI health-seeking behaviour. Yeah, absolutely. And I'm sure if we do another WOC GASOC journal club in the future, we would definitely look at some of the papers him and his team have written. Does anybody else have any more comments? Or Zahra, is there anything else you wanted to talk about?
I have basically covered everything I wanted to. Yeah.
I was wondering, the other thing we talked about at the start here is money and paying or reimbursing people for attending these kind of not workshop, what do the word they use, I can't remember, but attending these places to be counted. So, you know, other people then take their data and publish it. Are the people who then attend these places owed anything? Or if in this case they are being referred appropriately, does that just fit into the general cost of healthcare? And I suppose there is a discussion there as to whether or not patients and participants should be given money for attending services or research events. I don't know if anybody has any thoughts on
that. So I can see again that Ed's written, on a purely pragmatic level, it helps to reduce bias. So yeah, I think I do agree that it does, because you're probably going to see a lot more of the people you want to see, but again, I don't know, like maybe is it that I think, again, I think I'll just answer the question with a question, but do you is that money better used in other places for resources that are needed to help the people that are arriving rather than getting them to get there?
Yeah, it's a really tricky one, and I think it obviously sort of becomes a bit of a political discussion in that how much do people pay for services in various areas, and in Malawi I think it aims for free healthcare at the point of contact, but obviously doesn't financially compensate people for getting to and from hospitals and clinics, which becomes a part of that 3 delays model, preventing people from getting there. But then there are some studies that suggest actually if you're paying for some sort of treatment, you're more likely to attend rather than less likely, because the value and the it's very nuanced, but the way that the treatment is viewed changes. That's related to that. My particular example I'm thinking ahead is related to something called podoconiosis, which is a bilateral tropical lymphedema that affects adults and their ability to walk and attend regions where they have their treatment. And actually, if there were studies showing that if they were paying for treatment, they were more likely to attend. But again, there's a huge amount of bias involved in that conclusion. I wonder if anyone else who's joining us from a low middle income country has a view on this. Let me see who's still in the call at the moment. Lambert, do you have any views on this, or am I not really making a huge amount of sense?
Sorry, please, can you come again? Just want to.
So I think as high income trainees looking at research conducted in low income settings, often I look at it with the eyes of, is it fair for these individuals to be kind of taking part in research that's then published by high income trainees, where they've had to financially be affected in having to attend the process of having the research? I think in this particular project, probably balanced out by the fact that it's sort of part of their care, and they were kind of referred or highlighted as people needing orthopedic care. But how is it? What do you think? Sorry, that's a bit. I don't mean to put you on the spot, and you can just.
No, it's okay. It's okay. Well, I think the truth is, research is just beginning to get into full swing. At least I can speak for my country, Nigeria.
Mm.
Research is just beginning to gain traction. Formerly, we lacked a lot of data. So if you read a lot of textbooks, you get data from America, you get data from Europe, you get data from all the other countries. But African data is really very difficult. And even in the African texts that we use, it's also, we also find that for epidemiology of a lot of diseases that we study, we don't have data, but people are taking it upon themselves now to, despite whatever financial implications it may have, people are taking it upon themselves now to get data, do research, get data out there. So I think it's not a bad idea for this research is to be done and published in the high income countries, at least there's a positive coming out from it. The fact that we'll get our data out there, we'll get the facts of what's going on around here out there, and people will know actually, okay, that these are the issues, these are the challenges, and these are data coming out from these low and middle income countries. And then for future reference, they'll be added to training materials, added to course materials and all that. So we won't be making generalized conclusions again. Is to lump the whole of Africa together. We're going to have each country in Africa or each sub-region in Africa having their own data that we can make reference to in the future. So I think it's okay.
Okay, thank you so much for your input. Really, really valuable. Does anybody have anything else that they'd like to add? What time are we at? 11:45. I'll let somebody type. I had one other thing that I wanted to check. Zahra, did you see in if we go back to the thing about attending school, I think there was a this is here that not attending school. Okay, I think that makes sense. So that makes more sense. I was thinking because in the paper it says that only 63% of all Malawian children attend school, and I was thinking that 68.6 number was higher in the acquired non-traumatic at the bottom of the table there, but that's the opposite. So they are, oh no, they are attending
school. So this is the number attending school. So I think they did the average. I can't remember off the top of my head. I think it was something like 30 to 40%. I might be wrong. What is the average of that? Probably around 40-ish%. They said were actually going to school. So I think overall the number is definitely lower than the average population of children going to school.
Okay.
But I think the main point they were trying to highlight is that those with neurological conditions were less likely to go because they didn't have the resources to help with their disabilities, because a lot of them were functional, getting around, etc. And though they did say that there are schools with those resources, they probably just weren't they probably didn't fall into the right area to get there. So I guess it just highlights the need in that there need to be more schools with these resources. But that's really interesting. I didn't realize the number was quite so low, because then that means acquired non-traumatic, probably that number is around the same.
It might just be, I'm sure there's a bias amongst all that. I'm sure that if you have an acquired non-traumatic cause of MSI, it doesn't make you more likely to attend school. There must be something else at play there. But it's interesting, isn't it? Great. Well, thank you everybody for joining today, and thank you so much, Zahra, for such a comprehensive and interesting presentation and discussion. We will put this on YouTube on the GASOC by the GASOC account, and yes, hopefully watch out for more World Orthopaedic Concern and GASOC related journal clubs in the future, look forward to seeing you all at various other journal clubs again in the future. Thanks everybody.
Thank you so much everyone.
Bye.